This podcast is sponsored by Talkspace.
Last year, I went through many different life changes. I needed to take a pause and examine how I was feeling in the inside to better show up for the ones who need me to be my best version of myself.
When you're navigating life's changes, Talkspace can help. Talkspace is the #1 rated online therapy, bringing you professional support from licensed therapists and psychiatry providers that you can access anytime, anywhere.
Living a busy life, navigating a long-distance relationship, becoming a first-step father, Talkspace made all of those journeys possible. I could speak with my therapist in the office. I could speak with my therapist in the comfort of my home. I was never alone.
Talkspace works with most major insurers, and most insured members have a $0 copay. No insurance, no problem. Now get $80 off your first month with promo code SPACE80 when you go to Talkspace.com. Match with a licensed therapist today at Talkspace.com. Save $80 with code SPACE80 at Talkspace.com.
Welcome to IgAN Journey, the IgA Nephropathy Foundation's podcast. Here, we share information, tips, stories, and inspiration for living with IgAN. Using the power of our growing patient community, we are focused on funding research and building a network of support and ultimately finding a cure. To learn more about IgAN, to get involved, or help fuel our mission with financial support, visit IgAN.org. Welcome to this episode of IgAN Journey. High blood pressure and kidney disease often go hand in hand. In fact, for some people with IgAN, unexplained high blood pressure may be the first red flag that there's something wrong with their kidneys. The interrelated nature of the two is also why some of the first-line medications used to manage IgA nephropathy are those that lower blood pressure. Blood pressure is the force of your blood pushing against the walls of your arteries as your heart pumps. It's given as two numbers, so when you go into the doctor, you'll hear 130/80. The top number, which is systolic pressure, is the pressure when your heart is pushing blood out. The bottom number, diastolic pressure, that's the pressure when your heart is resting in between beats and taking blood in. Today, we are super excited to be joined by Dr. Jan Basile. Dr. Basile is a specialist in high blood pressure and a professor of medicine at the Medical University of South Carolina. He is also a fellow of the American College of Physicians, the American Society of Hypertension, and the American Heart Association. Welcome to the show, Dr. Basile.
Thank you for having me.
So many people with IgAN are first clued into the disease because they have uncontrolled or unexplained high blood pressure. Very simply, how are blood pressure and the kidneys connected?
Well, the kidneys filter all of our blood, and they are dependent on a number of hormonal systems to allow us to regulate volume in our bodies so we don't get dehydrated and have the correct amount of volume. They're also extremely important in allowing for electrolyte balance. So they're involved in sodium and potassium excretion. And there are a number of hormonal systems that affect the volume that goes through our blood vessels and gets filtered by the kidney. And these include the sympathetic nervous system, the flight or fight type system, and the renin, angiotensin, and aldosterone system that allows for sodium and water reabsorption in the kidney. So there are things within the kidney that can contribute to high blood pressure, and high blood pressure leading to hypertension causes kidney disease. So they're very interrelated. Hypertension causes kidney damage, and many chronic kidney diseases can be a cause of hypertension.
Okay, so it's almost a bit of a cycle, would you say?
They're interrelated. As filtration in the kidney goes down, things occur that cause blood volume to maybe increase and some of these hormonal systems to get exacerbated. And this can cause constriction of blood vessels like a hose. If your hose has a kink in it, the pressure behind that hose is going to be elevated. And that's somewhat of what happens when there is chronic kidney disease in the kidney. Blood pressure goes up. And this leads to more worsening of kidney disease. And in a disease like IgA nephropathy, where the glomerulus can be involved, there can also be protein loss. So
Okay.
the amount of protein loss as well as the filtration is what we look for and look at when we're managing patients with chronic kidney disease.
Okay. And I think that example is really helpful. So oftentimes people with IgA nephropathy, and I know with other chronic kidney diseases as well, they're often started on what we think of as typical blood pressure lowering medicines. Why is this, and how do these medicines work in a simple way?
Well, remember, IgA nephropathy is the third most common cause of either needing dialysis or transplantation. It is the most common glomerulopathy of all that we know. And the first two most common reasons that people enter dialysis or need transplantation are hypertension and diabetes. Diabetes is actually number one, and the two together are probably the third most common. So most people have diabetes, they have hypertension, they have diabetes or hypertension, and then we get into a disease like IgA nephropathy. Now, when hypertension occurs, these hormonal systems are activated. And one of the hormonal systems that's activated when there's chronic kidney disease is the renin-angiotensin-aldosterone axis. One of the drugs that is recommended as an initial drug in patients with chronic kidney disease is either an ACE inhibitor, an angiotensin converting enzyme inhibitor, or an angiotensin receptor blocker. These both reduce the activation of this hormonal system that contributes to worsening kidney disease. So, patients with IgA nephropathy, at the very least, should be on an angiotensin converting enzyme inhibitor, a drug like lisinopril, or an ARB, an angiotensin receptor blocker, a drug like telmisartan, olmesartan, valsartan. These are the ARBs. So this would be an initial drug to use when you're trying to control hypertension, but also trying to treat the chronic kidney disease.
You mentioned obviously later stages of kidney disease when we're thinking about potential dialysis or transplantation. How does one stage of kidney disease factor into sort of how you or other nephrologists manage patients' high blood pressure?
Well, in the management of hypertension, we're trying to avoid the progression of chronic kidney disease. And fortunately, we have tremendous advances in drugs for really the first time in my career that reduce the worsening of kidney function over time. So, one of the real important tenets of treating patients with IgA nephropathy would be to control the blood pressure. And the target in IgA nephropathy has been felt to be less than 125 top number and less than 75. And in general, when the top number is less than 125, the bottom number is usually close or at least less than 80, and that's pretty good. So we wouldn't necessarily chase the lower number. In the adult who presents with this disease, we're trying to get the top number reduced. It might have initially been 140, then down to 130s, less than 130. And in this particular disease, we're shooting for less than 125 and less than 75 to 80. Okay. So we're going to start with an angiotensin converting enzyme inhibitor or an ARB. If that's not going to get the blood pressure controlled, then we're going to add another medicine. Now, usually in hypertension, we're going to add either a calcium channel blocker, a drug like amlodipine or nifedipine long-acting, and or a diuretic, a thiazide diuretic. And the most potent thiazide-like diuretic we use is a drug like chlorthalidone. But in IgA nephropathy, when there is renal failure or a GFR less than 60, we are thinking about adding a drug from a new class called an SGLT2 inhibitor. And this is an important drug that in IgA nephropathy improves kidney function. In other words, it lessens the worsening of kidney function in IgA nephropathy. So after that ACE inhibitor or ARB, we're going to add an SGLT2 inhibitor. This usually has a small effect on blood pressure. So you may have had to use a calcium blocker or a drug like chlorthalidone or hydrochlorothiazide as that diuretic. But there really is a compelling reason to have a patient on an SGLT2 inhibitor. So clinicians should be looking for these drugs because not only does it slow the progression of kidney disease from worsening, but it minimizes the protein excretion, the proteinuria that is a hallmark of this disease.
Yeah, we've seen very favorable data with this new class of medications.
Yes.
All right. So you talk about one of the tenets is obviously lowering blood pressure. So patients knowing what their blood pressure is important, not only to protect the kidneys, but also, of course, they're at higher risk of heart disease as well. Why is it so important for patients to take their blood pressure at home and share it with their healthcare team at their various health visits?
Yeah, that's an excellent question. And the whole paradigm of what we're trying to accomplish has really shifted over the last 5 to 10 years. It's now recommended that clinicians make determinations and decisions on how best to control blood pressure based on the out of office, home, or self measured blood pressure. I was part of a paper, a white paper, written in the journal Circulation in 2020 on home or self blood pressure. The evidence suggests that outcomes are better in patients that have their home blood pressure controlled rather than office blood pressure controlled. We've known this for many years, but it's only recently that we've really required our patients to appropriately monitor their blood pressures at home and actually get those blood pressures fed back to the clinician so the clinician can make a determination on how to best manage the blood pressure. Do we have to add another blood pressure medication, etc.?
Okay.
Clinicians often think of reacting to the blood pressure in the office, but there are many things, including poor measurement technique, that occurs in the office that doesn't allow us to get the best measurement. So we really need to teach patients how to properly take their blood pressure at home, both in the morning, 2 measurements separated by 1 minute, and in the evening before they go to bed. Seated, back supported, feet on the floor, arm bare. They should not be disconcerted with a cell phone or a TV on or people talking to them. They should be alone, quiet, and properly taking their blood pressure. We also recommend at home that they take their blood pressure for 1 week out of the month. They don't need to be taking their pressure every day for 30, 31 days of the month.
Okay.
1 week will suffice. We'll get 28 measurements. We often don't use the first day's measurement. That's the alert day. That's when they're often anxious about it. And days 2 through 7 will give us 24 measurements. We look at what the control was when they first woke up, what the control was when they go to bed, and then we based when we give medicines and what long-acting medicines we're using based on the blood pressure results that we get.
So how can patients learn how best to take their blood pressure at home?
Yeah, this is an excellent question. There is a website called Target BP, one word, Target BP. It's a joint venture by the American Heart Association and the American Medical Association. And on that website, targetbp.org, you'll find a beautiful printable PDF that shows you exactly how best to take your blood pressure at home. And I would suggest everybody listening get on that website and download that PDF and just keep it by them when they take their home blood pressures.
In addition to the medications that you talked about earlier, what are some easy ways for patients to help lower or keep their blood pressure low?
Yeah, this involves what we call the lifestyle modifications or the non-pharmacologic management of hypertension. And although patients often think that it's about the medicines, we really have a tremendous amount, the highest level of evidence for 6 lifestyle modifications that can help lower blood pressure. The first one would be ideal weight, and any weight loss helps lower blood pressure. And we say that for each kilogram, 2.2 pounds of weight reduction, the top number, systolic blood pressure, usually goes down about 1 millimeter measurement. In addition to an ideal weight or weight loss, we want patients to eat a healthy diet. This involves a diet called the DASH diet, but it's basically a diet that's high in fruits and vegetables and grains, low-fat dairy products, and we want to reduce both the total and the saturated fat. The other thing that we're really promoting now, which we've been doing for some time, is to reduce sodium intake in the diet. But the new thing is to enhance dietary potassium. And of course, this, as you go through the grocery store, you know that potassium can be obtained tremendously from fruits and vegetables.
Yeah.
And of course, they are some of the more expensive things in the grocery store. So social determinants of health interact here, food poverty, food insecurity. But the ideal diet is a diet that's low in sodium and high in potassium in terms of the diet. Now,
Yeah.
many patients do not abuse the salt shaker, but where they get their salt in America, 70% of the sodium we take in is through canned foods, frozen foods, and processed foods. So one really needs to look at the labels and look at the sodium content in whatever they're eating to make sure they can reduce their sodium and increase their potassium. The other lifestyle modifications are any degree of physical activity. It can be aerobic, it can be resistance exercises, and it can even be weightlifting. But aerobic exercise seems to be the best. And then finally, moderation of alcohol. And we say a drink is 5 ounces of wine, 12 ounces of beer. And depending on the proof of the liquor, it's 1 to 1.5 ounces of liquor. And we allow women no more than 1 drink a day and men no more than 2. But I can tell you, practicing blood pressure control for many years, many of our patients are drinking more alcohol than they should for their degree of blood pressure elevation. So those are the lifestyle modifications that are extremely important in controlling blood pressure.
Very helpful. What's the role of other factors? I know patients often ask about this, like sleep or stress on blood pressure.
Yes. Patients with IgA nephropathy need to be very tuned in to their LDL cholesterol. And I would think most of them should be on a statin at a minimum, but they should get their LDL controlled to what the target would be for their degree of cardiovascular risk. In addition, they should certainly avoid smoking. They should get their diet into a low salt diet and potassium based on their kidney disease. One of the hallmarks is that one shouldn't be using high potassium foods if you already have significant kidney disease, because the kidney can no longer excrete the potassium and you could get hyperkalemic or high potassium, and that can be very dangerous. But in addition to the ACE or the ARB, the blood pressure less than 125, the cholesterol, LDL cholesterol, controlled, usually at least on a statin, the low salt diet, no smoking, the SGLT2 inhibitor. This is a pretty good cocktail for patients doing about as much as they can at the present time to get their disease in the best control it can be in.
So you talked a lot about how there's this interconnectedness between the kidneys and high blood pressure, but we also know that high blood pressure over time can really elevate someone's risk for heart disease. So what are some of the things that patients with IgAN should be thinking about in order to try to really be able to reduce their risk?
Well, I think people with IgA nephropathy should know the amount of protein they're excreting in their urine and their blood pressure and what it usually runs. Of course, with their clinician, they want to minimize protein loss through the kidney, which is a sign of more significant glomerular disease. The more protein you excrete, the more significant the disease is on the colander, if you will, that's allowing protein to get through the small holes in the glomerulus of the kidney. And of course, you want to lower your blood pressure so that the control of all of the hemodynamics within the kidney can be best protected so that you don't lose filtration. In addition, of course, the lipids and the cholesterol and the LDL should be at its target based on what you and your clinician decide your risk determines your LDL cholesterol. And of course, your diet will contribute in all of the risk factors that we're very concerned about. So I think if you get your cholesterol in check, your LDL cholesterol, get your blood pressure to target, know if you're spilling protein in your urine, know if your weight is ideal, minimizing your salt, minimizing your alcohol, working on these lifestyle modifications. Very often, a dietitian is extremely important to meet not only with the patient, but also with the food buyer and the food preparer so that everyone's on the same page in terms of the diet that the individual should be on.
I think that's great advice. And I hear that all the time where people struggle and they don't know where to start. They often think it's the table salt, but it's actually not. As you said, it's hidden in a lot of the products that we buy and prepared foods. Is there anything new and exciting that's coming up for patients with IgAN, especially as it relates to lowering blood pressure and protecting the kidneys?
Yeah, there are things that are coming out that are actually available now. And remember, IgA nephropathy or Berger's disease is a new disease in that it was first described by two French colleagues in 1968. So there hasn't been that long of a time span to really do as much research as one might have liked. Nevertheless, there is a new class of drug that is FDA approved, which is an endothelin antagonist and an angiotensin receptor blocker, 2-in-1, one pill. And it's called sparsentan. So it blocks both the endothelial vasoconstriction that can occur at the blood vessel, the tightening of the blood vessel, as well as the angiotensin elevation that occurs from the renin-angiotensin system. This is a drug that was FDA approved in February of 2023, but it is indicated in patients that still have difficulty with protein excretion after they're on both an ACE inhibitor or an ARB and an SGLT2 inhibitor. Other drugs that I haven't mentioned would be drugs like mineralocorticoid receptor antagonists like spironolactone, known as aldactone or eplerenone. These drugs work further downstream from the renin-angiotensin axis to block salt and water retention in the kidney. And they can also be used for protein excretion to minimize that, as well as blood pressure control. People are still doing research on steroid use, but there is a targeted steroid called budesonide, which works in the ileum, in the small bowel. It is taken orally, but it actually targets the lymphoid tissue in the gut, which is involved in the IgA that's increased production. That is one of the factors in the so-called four-hit hypothesis of IgA nephropathy. So between the ACE or the ARB, the SGLT2 inhibitor, are you a candidate for sparsentan? Is your blood pressure controlled? And would you benefit maybe from a drug like budesonide, a targeted steroid, without the systemic effects and side effects of drugs like prednisone, etc. These are all things to discuss with your clinician. But it is an exciting time for this disease.
Yes, we are super excited as a foundation, given the number of therapies that are currently in study. We hope that obviously that'll push the treatment pathway forward for many of these folks who we talked about are often in the prime of their lives when they find out that they have it.
Yes, it does affect people usually less than 50 years of age, and it often can start at age 20.
Yeah. Anything else that you think is important for people with IgAN to know about in terms of managing their blood pressure?
No, I think patients with IgAN need to have a nephrologist that they feel very comfortable with, an excellent primary care clinician that can oversee all of their care, and other specialists that might be necessary to help in their care. But I think the two main individuals would be a primary care clinician looking at the non-renal effects of this disease and all the other risk factors that need to be modified and controlled, as well, of course, as the nephrologist.
Yeah, I think that's an important point. I think helping patients to understand how to have their clinicians talk to one another and coordinate is so important to be able to optimally manage this disease.
Yeah, absolutely.
Well, thank you so much for all of your tips and the information about blood pressure, how it's interrelated with the kidneys, and all the other helpful hints that you gave us. We really appreciate your time. So thank you for being with us.
It's been my pleasure to be with you all.
We also have information about the kidneys and blood pressure, tips, and a blood pressure log available at IgAN.org. Thank you for joining IgAN Journey, the IgA Nephropathy Foundation's podcast. Here we share information, practical tips, stories, and inspiration for living with IgAN. Everyone's at a different point in their IgAN journey, but we're here for you. You're not alone. To learn more about IgAN, to get involved, or help fuel our mission with financial support, visit www.IgAN.org. The information and opinions shared in IgAN Journey are not intended to serve as or replace medical advice. Always speak with your nephrology care team about treatments that are right for you.